accessible system, and refocus our efforts on building a national grassroots campaign to win Medicare for all. We can do it incrementally. We just have to make sure incremental steps are moving us towards that public infrastructure and not deepening the involvement of the medical industrial complex. So from a labor perspective, we're looking at the impact that corporate privatization has brought us through a few of these industry trends in healthcare that we are seeing pop up. These trends really take us further and further away from what's in the best interest of the patient and the provider, with schemes such as Home All Alone, also known as Hospital at Home, using artificial intelligence and algorithms, this lean management model, and consolidations and mergers. Again, all of these tactics and strategies are harming healthcare workers as well as patients. We are labor. We care about the workers as well. Home All Alone, in case you all haven't, don't know a whole lot about it, is really aimed at keeping patients needing acute care out of the hospital. Instead of admitting these patients who would otherwise be traditionally hospitalized, they are sent home with an iPad and a smartwatch to be admitted for hospital care at their home. The patient is told a team of medical professionals will monitor them remotely from a medical hub. These hubs could be many miles away or even in a different state from the patient. From the hub, the care teams are sent out to check on the patient as the need arises. In cases where a provider needs to physically be with a patient, the remote team will then send out a nurse or what they are calling an upskilled paramedic. These Home All Alone schemes were born of an unholy alliance between a profit-driven hospital industry, technology giants, and venture capitalists seeking to reap profits by replacing hands-on skilled hospital care with robots, gadgets, and less skilled contract workers. Nurses in particular are shocked by the non-existent safety protocols that exist in these Home All Alone programs. Private advantage, corporate advantage plans are at the tip of the AI and algorithm iceberg, as they're using artificial intelligence to systematically deny skilled nursing care to elderly patients with serious health problems. And this is according to senior advocates and 2 class action lawsuits that have been filed. Here in Minnesota, a local TV channel did an investigative report on this topic. This you see on the screen is Bill Draxler. Bill's a 96-year-old. He broke his hip. And after spending 5 days hospitalized, his doctors prescribed skilled nursing care to help him recover and regain strength and mobility. Well, the AI algorithm that his Advantage plan was using predicted that Bill only needed to receive 17 days of care. However, his medical records told a very different story, showing how much care he still needed. As the 18th day approached, Bill's medical team informed the Advantage plan that he still needed maximal assistance just to stand up. His self-care performance score was a 0 out of 12. But the Advantage company's algorithm left the family with 2 choices: let Bill return home, unable to function without multiple caregivers, or pay thousands of dollars out of pocket to stay in the skilled nursing facility. The insurance companies are banking on the fact that these are vulnerable adults in times of crisis and injury, and that they won't appeal such decisions and denials of care, resulting in some patients dying in the process. But when patients do fight, they almost always win, because nearly all of the claims denied by Advantage plans would have been covered by original Medicare. As trade unionists at the labor campaign, we also need to be aware of the impact on the workers within the corporatized healthcare system. Lean management models come out of the auto industry. It's basically doing more with less. So here's what nurses have said that this looks like in the reality as the CEOs attempt to run healthcare like a factory assembly line. Nurses are not receiving adequate training on units. They are being floated to and are told that they're just to figure it out. Nurses are not supported in refusing unsafe assignments. Instead, they are threatened with discipline and job loss unless they take the assignment. Emergency rooms are beyond maximum capacity, with patients being boarded in the ED on gurneys and hallways, lacking privacy and a healing environment. ED nurses are not inpatient nurses, and yes, there is a difference. Workplace violence continues to escalate in our hospitals, and all of this is resulting in nurses leaving the bedside in droves due to the untenable working conditions inside the hospitals. What would we do in our hospitals without our nurses? And then consolidation and merger frenzy has been a direct result of managed care, and it is raising healthcare costs, not bringing them down, and it is causing our care providers to experience moral injury. Huge healthcare corporations are making decisions about where to open or close healthcare facilities and shut down services based on their bottom line, not on the community's healthcare needs, creating healthcare deserts all over the country. Hospitals need to return to their roots as a community asset and not a corporate balance sheet asset. So I know that One Payer States has been doing some terrific work raising the horrors of Medicare privatization. After all, we don't want Medicare Advantage for all, we want Medicare for all. The privatization of Medicare is probably the most obvious and egregious of the privatization efforts, although the privatization at the state level of Medicaid is right behind it. When I talk about the privatization of Medicare with trade unionists, I make sure to note two things. First, I am not sharing this information to shame or blame anyone. It's understandable why many retirees choose a Medicare Advantage plan instead of traditional Medicare with a Medigap or supplemental plan because we're on a fixed income and we have to do what's affordable for us. And healthcare is expensive and nothing is being done to get to the actual cost and control those costs. The same is true for why unions many times have negotiated Medicare Advantage plans for their retirees and why employers moved their retirees into Medicare Advantage plans. It's about affordability as it relates to the high cost of healthcare in general. But it's also important for retirees and unions to know that Medicare Advantage is not Medicare. Medicare Advantage is the misleading name given to the privatized portion of Medicare, the portion in which tax dollars are funneled through insurance companies. I also think it's important to note that the privatization of Medicare and all public health programs has been a bipartisan effort. That's why, regardless of political party or ideology, when it comes to healthcare, it's in all of our best interests to work together to protect and advance public health. And these privatizers, the corporate C-suite executives, they aren't even hiding their complete lack of humanity, as you can see by the quote from CVS Health Chief Financial Officer Tom Cowhey. He said, "The goal is margin over membership. Lose up to 10% of our Medicare members? That's okay." It really does beg the question that is being asked, as you can see here by one of the labor campaigns and all of our allies in this fight, People's Action. Who are you to decide if we live or if we die? And that's the Care Over Cost campaign. The incredible PNHP harms report is foundational to our educational work at the labor campaign, and it's worth highlighting here as it excuse me, as it ties directly to the labor campaign's work on deprivatization and Medicare Advantage. I think these conclusions are particularly helpful in understanding exactly what we're dealing with here. Overwhelming evidence that insurance corporations are harming people in order to make money. No surprise to anyone here, nor to us really in the labor movement. I mean, it's literally why unions exist. Medicare was created to serve the people. Corporate health insurers have shown that they cannot be trusted to carry out that crucial mission. Let's see here. So this is the level the playing field resolution. I'm not sure how much you all have had a chance to talk about this, but I'll touch on it and then I can answer questions when we get to the end here. But both the Washington and Minnesota State AFL-CIO federations have passed a resolution with the Maine State AFL-CIO Federation considering this resolution at their September meeting. Now, the resolution was first drafted by a retiree council in Washington State, Pizarra, that lays out how labor should view the privatization of Medicare and the position we should take to deal with the fraud of overpayments to these advantage plans and to protect our Medicare funds to both save and to improve traditional Medicare. With labor engaged in the negotiation of Advantage plans, the labor campaign for single payer, as I said earlier, is creating education programs and guidance for leaders and members and negotiators about the realities of these Advantage plans, and are working to get a significant number of unions, labor councils, and state feds to adopt this resolution. We're hoping that in doing so, we will open up some space within the House of Labor to discuss whether or not labor should, in fact, participate in the privatization of Medicare. I'm going to switch hats now, and I'm going to talk a little bit about some of our ongoing work that's pretty exciting here in Minnesota. We are establishing some incremental pathway legislation that I want to talk about, and just sort of let you get a peek at how we're seeing that play out as we create a statewide campaign plan to win the Minnesota Health Plan, which is the name of our state bill. Excuse me again. So Healthcare for All Minnesota's organizational structure was set up in a way that we hope will be easy for us to transition to a statewide campaign structure once we're ready to launch that campaign. One of Healthcare for All Minnesota's committees, the Coalition Builders Committee, has worked to bring together labor, community organizations, disability, LGBTQIA+, and BIPOC organizations to create what we call the Health Justice Allies. The HGAs, as we lovingly refer to them, have asked that we create a campaign plan now that would provide them with a very clear vision of why, how, what, where, and when of their commitment would be required to make such a campaign successful. So we are in the midst of putting that together, and I'm going to lay out what we've got so far for you all, because who knows, we're all working on this on a state level. Maybe some of this will be helpful for you as well. The plan's narrative includes defined goals that are centered on coalition building, organizing, education, and of course, creating grassroots power to win. Our main statement is that Healthcare for All Minnesota will build a powerful coalition to pass legislation that creates a state-based healthcare plan for all Minnesotans, regardless of age, income, employment status, health condition. We're adding race into there. We just noticed that this morning, or zip code. So we are really going to try to build a powerful grassroots campaign, because we know that's what's going to take to win. The next few years, we will be all about moving infrastructure building legislation that are going to bring us closer to our goal of single payer, which would include expanding coverage in the meantime, deprivatizing public health programs, dealing with medical debt, and making it clear who's to blame for the current obstacles and costs that are preventing people from being able to access care. So you can see here, we've got a couple of different things we're mentioning there as stepping stones that we want to be working on here in the near future. I mentioned, I think last time that I was here, some of the positive legislation that passed in 2023, which you can see noted on this slide. The legislation, this legislation really becomes a foundation for the infrastructure of our work that we are going to try to do to really build up that public program. We've got a cost study coming on the Minnesota Health Plan compared to the current system. We are covering undocumented immigrants in our Minnesota Care, which is a basic health plan under the Affordable Care Act. This is huge, really, really important work. We are working on this plan for deprivatization. We now have a prescription drug affordability board. We've done some regulations on corporate mergers and hospital closures, and that work is going to continue in the next session as well. We've got reports coming on administrative waste that happens within our public health programs. There is development going on of a public option, and then we have some really good Medicaid reform that went on, particularly around no cost sharing for Medicaid patients and keeping children 0 to 6 on Medicaid, even when their parent goes, over that little hump of to 140% of, federal poverty level, and then they lose out on their care regimen. And so 2024, we continue to still pass some really good legislation, solid pathway legislation that pushes the privatizers further away and continues to center our patients and providers. Attorney General Ellison's office moved some significant change in how medical debt is dealt with in Minnesota. I just was on a roundtable with him today, and many in our coalition that worked hard together to make this happen. Hospital closures and shutting down needed medical services were strengthened again and are going to be continued to be looked at. I'm meeting with the Attorney General in a few weeks, and I really want to talk with him about how he could, how he can get more authority to stop private equity literally in their tracks from, purchasing healthcare entities like nursing homes and all of the abuses like we see going on with Steward out in Boston and in Massachusetts. The legislature began the important work of reining in prior authorization nonsense that goes on. And the deprivatization of public health programs was expanded to include specific details to be looked at when it comes to providing a plan for direct contracting between the state and providers, and includes the need to connect social determinants of health to our public healthcare system, which of course we all know is terribly important. So these legislative efforts has changed the Minnesota healthcare landscape in some very positive ways. But we also have some landscape challenges that are coming up before us that we have to deal with. So here in Minnesota, I don't know about you all, but we've been engaged in this absurd circle of hell known as reinsurance. And this is where the insurance companies selling products on the Affordable Care Exchange, Affordable Care Act exchange here in Minnesota, known as MNsure, come to the legislature and whine about how they're having to, they're going to have to increase the premiums by double digits because, people are, I don't know, actually using the product. And how dare they do that? And therefore, the state is going to need to reinsure the insurers to keep the premiums within an affordable range. Needless to say, that is all BS. I mean, since they bank plenty of dough and could easily reinsure one another. But no, Minnesota put $700 million, almost $750 million, into reinsurance a few years ago. That reinsurance money expires in 2025. That's going to impact that individual market, which in Minnesota has only about 146,000 people on it. But of course, we still want to make sure that those 146,000 people are able to access care. So we're thinking about other creative ways to deal with that issue instead of putting more money into the bank accounts of the private insurers. We could do things like direct subsidies from the state to the patient, to the individual person, so they can see that that's the government that's helping them actually afford their health care in a very real and very direct way. And it certainly points out that the insurers are the bad guys here. We also face, of course, all of us, the potential of losing the enhanced federal advance premium tax credits due to an expiration date of December 31 of 2025. So it would be a double hit in Minnesota if that happens for those purchasing on the exchange. Never seems to be a dull moment when we're trying to stay ahead of the medical industrial complex. So based on that good work of 23-24 and the legislative session and the potential impacts for 25-26 healthcare landscape, we first want to focus the campaign on building the actual structure of the campaign over the next 18 months. The campaign is going to give organizational partners the tools to build member engagement, empowerment, and organizing ability within their organization. Being part of this healthcare campaign for those organizations is going to mean this. It's going to mean that we're all going to believe in the campaign's purpose and the outcome. All organizations are going to see this as a campaign that they can use to build their own organizational power. They're going to see this as a campaign that builds capacity and skills for their members, turning their members into organizers, learning how to have one-on-one organizing conversations, how to talk to legislators and be a citizen lobbyist, real skills-based activism. And the campaign will also make it easy for these organizations to determine what their role is, what aspects of the campaign make the most sense for them to be able to plug into, and that this is actually your share of the pie, here's our share of the pie, and here's how we can all be part of this campaign. We certainly will be engaging with our partners in a power analysis that identifies key decision makers and influencers, and who would have the authority that best would meet the demands that we are asking for, right? We have to identify those people. And then this would include elected officials, certainly at all levels, but also agency staff, the staff of legislators, and community leaders. We will also identify our opposition, both corporate and political, to build a strategy to toxify their public image, neutralize their opposition to our movement. We will identify potential new collaborators and communities to reach out to and work on effective ways in which to approach them, figuring out who is the best messenger. We'll center our messaging on these questions. Why is this right based on the evidence? Who needs to hear this message and how are we going to deliver it? And again, who is that best messenger? Why is this good politics? Why is it good business? Who needs to hear that message? And again, who's the best messenger? And finally, why is it right based on our morals and our values? So we will be hopefully working to develop a clear and concise statement of our principles in order to articulate our vision for this campaign. So the campaign timeline includes work now on the studies, reports, and deprivatization plans we have in the works. That work must be evidence-based and not steeped in managed care fiction, because the outcome of that work could impact our ability to move forward on deprivatization and the Minnesota Health Plan itself. 2025, we want to focus on some bridge programs to deal with that loss of reinsurance and the potential loss of the federal advance premium tax credits. We want to build the case for deprivatization through accountability and transparency legislation and explore the full deprivatization of other state pools. We have public employee pools, right, for insurance. We want to see where could we maybe use those as another example of how the public can actually do it better and more efficiently. So 2026 is going to be where we're going to up the ante on toxifying that corporate healthcare, continue education on the benefits of deprivatization, and begin hopefully drafting the bill to actually enact direct contracting between the state and providers, utilizing the findings of the studies and the reports and the plans that are coming forward. And in 2027, the Minnesota Health Plan will be reintroduced with the financing that we will get out of that report in 2026. And that'll be a major focus, of course, of the campaign from that point going forward. So the final pieces of the campaign will be to literally design it. What's our brand, logo, marketing, social media content, hashtags, and of course, we'll need a budget. So fundraising over the next few years, along with looking to our ally partners to make commitments to resource the campaign, which is equally as important. So these are the basics, with much work still to be done. We don't have it all flushed out entirely yet. We'll be working with some of our allies and firming up the plan, and hope to have it ready for presentation to the health justice allies and our members sometime this fall, preferably actually pre-election, at least for our members, probably post-election for the health justice allies. We're committed to figuring out a statewide campaign plan to win the Minnesota Health Plan that integrates all the great work that's already going on, that can be used to engage more people, organizations, and elected officials, and it can be chalked up as wins along the way to winning the Minnesota Health Plan. You know, I think it's critically important in this moment for the movement to recognize the importance of transitional stepping stones that will help us rebuild the public health care infrastructure. As I've been saying over and over again, toxify and call out why the system costs so much and where obstacles to care like networks and deductibles and prior authorizations are coming from. We have to take every chance we get to point the finger at corporate healthcare as they continue to profit off human suffering and death. And we have to demonstrate that another world is indeed possible, one that centers our common humanity. As Minnesota's governor and VP candidate Tim Walz says, one person's socialism is another person's neighborliness. So let's keep highlighting our neighborliness. And with that, I welcome the rest of the nation to Minnesota Speak. So I will switch over now to questions.
Wow, thanks, Rose. Let's see. Cheryl, you have the first question. Cheryl Stevenson on mute.
Yes, yeah. I'm trying to get off the. Do you use the term single payer, and how much do you talk about the phrase "lower the playing"?
Or level the playing field.
Yeah, level the playing field. What are your slogans, in other words?
Yeah, they're not all yet defined, but I mean, so single payer I use here because it's us.
Yeah.
And I know it's a safe place to use single payer, right? Because a lot of people say, well, who's the single payer? Am I the single payer? Right? So people get confused by that. There's been a lot of testing and focus group work that's gone on around what do we call this movement. And, there are some people who will say they don't like it, but I'm telling you, the focus group work that's been done on it, people get what Medicare is. And even if they don't think it's perfect, which it's not, and it needs work, they know at 65, they're going to have some kind of a base guaranteed for accessing healthcare. So that sort of triggers something for them. So saying Medicare for all. In Minnesota, we call it the Minnesota Health Plan, and we are just finding out, Ann and a handful of my fellow activists here just did something called Farm Fest in Minnesota, in the deep red territory. God bless them for doing it. It was not fun for them, but we had our banner up saying the Minnesota Health Plan, and people thought we were selling insurance. Right? That the Minnesota Health Plan is the name of an insurance. So we're kind of rethinking some of that message at the same time that we want to brand it as being a good way to do healthcare, right? We also have to figure out how to get them to the booth to have the conversation and not scare them away thinking that they're going to get a conversation about, another type of an insurance plan to purchase. So we use it sparingly where we know it makes sense. And it's pretty easy to say, no, the single payer is just, it's a single payer is about a streamlined payment system. That's all it is. We don't need all those people in between the provider and then where we send our money. Send our money to the central place, and that central place sends the money to the providers. So there are ways in which to do that. Leveling the playing field, I'm telling you, that is working big time inside the House of Labor. And I am going into some lion's dens with, some unions that have done some negotiations of their retirees into Medicare Advantage. So I, again, try to be very careful about not making it a blame game or shame game, and trying to say, this is a problem. We should all be aware of the problem. And then we should figure out how to do better with this. Because I don't think any of us want to see Wall Street own our Medicare fund, which is going to happen within the next 5 years if we don't do something to stop it. I did a presentation at an AFSCME Council 5 convention here in Minnesota. That's the largest AFSCME council here. And when I got done, a man kind of chased me out the door and wanted to talk more about it and said, this is one of the best presentations we had here. And then I looked at his button on his lapel and it said Trump 2024. And I thought, well, if I can have a conversation with someone that clearly sees the world very differently than I do, that still thinks that this is wrong, what's happening inside of our Medicare fund, and that actually Medicare Advantage plans shouldn't be able to rip us off, maybe there is some hope on this issue that we can find some common ground.
Yes. Thank you, Rose.
Sure. Hey, Betty, go ahead.
Hey, how are you doing?
Good. How are you, sister?
Great presentation. I'm going to give you a heads up that in May, late May or early June, I would love an update on all of this in a 20-minute, just not Medicare because they have other lectures, but this is for our medical students in that we do this internship with by Zoom, just like the Minnesota Health Plan. I'd love to have that before we do a panel on state-based stuff.
Okay.
So my question, in Vermont, we had a bill passed in 22, and it took us over a year to choose the consultant to actually go forward and assess what all is wrong with our healthcare, especially the hospital system. And looking at the AHEAD program, I'm not sure whether you've looked at the AHEAD program that CMS is doing for trying to move hospitals away from fee-for-service and do more value-based care, of course, And in the presentation that this consultant did, Oliver Wyman is the consulting group, and Dr. Emery is the consultant who's doing it for us. He says that the insurance companies in Vermont, and there's only a couple, are actually not making money, and that they're losing money. They're running out of the funds that are required to be safe. Now, Blue Cross, the two MVP and Blue Cross Blue Shield are nonprofits, and it may be that they spend so much money differentiating themselves and doing their actuarial blah, blah, blah to create differences in their products and to exclude people and do their prior authorization analyses and stuff. It may be that they actually aren't making money, but we can't use it when he's gone around and sounds like he's really gathered so much information and now he's going around saying this. We can't use the language of painting them so toxically if he's saying that they're not actually making money. So
They're making money. we got nonprofit insurance companies here in Minnesota too. That's a
was-
misnomer.
I was thinking that our Blue Cross Blue Shield was actually like administered by the Minnesota Blue Cross Blue Shield now. I thought we got this notice like a year or so ago. I don't know. So you're thinking that he just got a song and dance? Or that-
I'm sorry, but are you kidding me when, I mean, they are absolutely making money. I mean, when they have piles of reserves that they don't use to, buy down the premiums to be able to make them more cost effective, right? For, or affordable on the exchange. I'm sorry, I don't buy it. I guess, and they know how to hide stuff. That's for darn sure, and make it look like they're hurting like crazy. And in reality, that's just not the case. I don't
So-
know how in the world they could be.
Yeah. So one thing is that Vermont actually is very regulated, and it's harder for them to get away with not providing care, although they certainly figure out how to do it still. They certainly have the prior authorizations and make people jump through hoops, and people sometimes still have worse outcomes because of the hoops they had to jump through. But I'm
Yeah.
just wondering, after he's gone through and done this analysis, like how do I as a private individual how do you get to the money numbers? How do you get to those? Who gathers the numbers that you can
Yeah,
make
I
those?
mean, it is about, where is the beef, right? And prove it to us. But of course, whatever they show you is like what they want to show you. So it's always, is there somebody that could actually do a forensic audit of the reality of what that company, but it's a private company, so they don't have to tell us squat.
Yeah,
Right. I
okay.
mean so I don't know that I have an answer for you, Betty. Honestly, I mean, I would just, I continue to push back on it. You're going to have to prove that to me, considering that, pretty much every insurance company that I know of in this country, the big ones anyways, and the Blues are certainly a big one, are reaping in some pretty significant profits.
Thank you. Thank you. And are you doing any regional work, like working with any neighbors on trying to do a regional plan instead of just a state one? Or are you just like totally
No,
focused in, yeah.
We're just, Minnesota's just looking at Minnesota.
Yeah.
We're a blue island in a sea of red. So I doubt that we would get much much traction on anything like that. But no, we haven't done anything on regional. We've been keeping it in-house, just
Yeah.
Minnesota.
And one suggestion on one pair of states, I actually need to let other people ask their questions. I'll move on to Barbara Pearson. I'll come back if there's time.
Great, thanks,
Thank
Betty.
you. Thank you.
You bet, of course. Hi, Barbara. Oh, you're on mute.
There, sorry about that. So, thank you so much, Samantha, for coming. I can't wait to see the video because I need to see this twice. You said so much. and I did
Yeah, I
see
know.
the video,
Sorry.
um, because you had so much to say. This morning, I was greeted by the story about United Health suing Minnesota because they're
Yeah.
not there's a bill that forbids making a contract with a for-profit organization. What if the for-profit organization gets, Paul sent me, they got a D- from the Better Business Bureau for the thing. They certainly can't show that they've saved the people money. So why do we have to make these contracts? I just have
Yeah,
never
well,
understood.
that's the crux of this whole thing. So Minnesota always, pre-2017, Minnesota's public health programs were set up in a way that when they decided to privatize some of those public health programs, the privatizers could only be nonprofit. They couldn't be for profit. So United Health is, like I said, it's in our backyard here. It's a big for profit. United Health cannot up to 2017 could not participate in our Medicaid or our Minnesota Care programs. Now, come 2017, what happens then is we have, and I don't think it was both the Senate and the House, right, you guys? I think it was one or the other was, one was Republican, one was Democrat. The governor was Democrat, trying to get some things done in the state. And the governor compromised and allowed a bill to pass that said those programs would be opened up to for-profits. Immediately, the following session, the Democrats took back, I think, both the Senate and the House and put a moratorium in place to like, wait, this is probably not a good thing for us to do. We let's hold off, right? And figure this out. They've had the moratorium in place for a while. And just in this last session in 2024, was it? Okay, thanks, Mark. That's what I couldn't remember is
And was
whether,
it Mark Dayton that helped us out? with
yeah, it was
that
Dayton.
hold?
Yeah.
Yeah,
It was
the
Governor
Democratic
Dayton.
governor, yeah.
Yeah. And both the House and as Marcus said, both the House and Senate were Republican. So just in this last session, they passed a bill that said they couldn't quite repeal it entirely, which is what the best thing would be, but they did still keep it in a way that supposedly in our public health programs, if you want to participate, the private insurers have to be nonprofit. So United Health is suing the state of Minnesota, saying they have every right to participate and bid on that business. And I think, according to one article that I'd read, our Department of Human Services apparently even did some kind of a contract with them to provide some bids back in 2022. The moratorium was still on. I find that extremely confusing to me. These are all questions that I have in the hoppers for a couple of legislators I'm literally meeting with tomorrow to see what I can find out about this. Plus, I'm going to raise it with the Attorney General because he, of course, will be representing the state. And we got a pretty terrific Attorney General here with Keith Ellison. So I'm very intrigued to see what he's thinking about this as well.
Thank you.
So it's a nightmare. It's just ridiculous. But we did $35 emergency insulin here a number of years ago because one of, a 26-year-old died of diabetes in the United States of America, the richest country in the world, just because he couldn't afford his insulin because he went off of his parents' health insurance at 26. And so we have $35 regardless of income, insurance, blah, 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 right? If you need emergency insulin, you will not pay more than 35. Eli Lilly sued us over it, right? I mean, this is what we're dealing with in this day and age. It's horrific. Just horrific. So thanks for the question though, Barbara. Yeah.
Well, I mean, I just want to find out how we can not make contracts with these people.
Well, and that's what we're trying to do with the deprivatization work is we have a strong leader in the House, Representative Tina Liebling, who has been chairing our Health Policy and Finance Committee. And Representative Liebling really, really understands this so deeply on a policy level that when she wanted to get legislation passed that said we should deprivatize, and the Department of Human Services got all twitchy about it and said, well, maybe we should just study it. And she said, I don't need to study it. We already know that they're taking money and not spending it on healthcare. I want to see a plan on how could we proceed to actually deprivatize. And that would be not signing those darn contracts in the first place inside of our public health programs. That's ultimately where we want to go, Barbara.
Thank you.
Richard, I'm
Richard.
almost afraid for you to ask me a question. You are far more educated on this than me, but go for it.
Well, here's my question. In New York, our sense of the obstacle to enacting the New York Health Act is the opposition of virtually every public employee union, state and local. A lot of the labor movement supports the bill, but in a state with both houses having Democratic majorities, the likelihood of passing a bill that is strongly opposed by the public sector unions is pretty slim. My question is, what is the union, how does it shake out in Minnesota? And what do you think you can do to win over either support or at least non-opposition from unions that are not on board yet?
Yeah, really good question, and I'm familiar a little bit with what you all experienced in New York regarding the New York Health Act. So one thing is, so AFSCME and the Education Minnesota. Here in Minnesota, we don't have two teacher unions, we have one. So, there's the NEA and the AFT. Well, in Minnesota, they are married, so they're one. So it's FTEA together, right? And they are I think they are the largest, and AFSCME is the second largest, and just in unions, period. But then you throw in the fact that they are both public employee unions, right? So when I was working for the nurses, and we went to a state AFL-CIO convention, and we were bringing forward a resolution because they already were on board with Medicare for All. They'd already passed a resolution on that. We wanted one specifically for the Minnesota Health Plan, right, for the state. So when we were bringing that forward, we did one-on-one meetings with the leaders of Education Minnesota, the leaders of AFSCME, the leaders of a handful of, SEIU, other unions. And I'm very pleased to tell you that when that resolution hit the floor, we were able to convince at that time the executive director of the AFSCME Council and the executive director the president of Education Minnesota to actually go up to the microphones and speak in favor of the resolution. Now, does that mean that they're working their tails off to help us pass this thing and make it happen? Unfortunately, no. But it's relationship building. And one of the things that and I know, Richard, you know John Marty, who is the author of our bill, right? One of the things I've been trying to encourage John to do, and I think we have to do it before we get the finance cost analysis study that's going to be coming down in 2026. I think we have to create a labor roundtable and bring to the table even the unions that we know, and this is going to be probably here in Minnesota more the building trades, maybe even more so, potentially still some public employee unions though, but bring them into the table and be like, what do you like? What don't you like about this? What are you worried about? What do you see as the obstacles? Are there changes we could make that don't weaken what we're trying to do here, right? But that deal with your issues. At the very least, we're going to make darn sure that nobody is able to say we weren't in the room, we weren't seen as stakeholders, our voices weren't heard. And we're just constantly trying to, the nurses in particular in Minnesota were just really stellar at this. We constantly asked at conventions and conferences, do you guys do education days? Do you do breakouts? Let us come in and talk about why we should take healthcare off of the bargaining table and why it would be better for public employees. My God, before I represented the nurses for 25 years, I represented public school employees. When I was in California, we ran a massive campaign just by going around to school boards and being able to show them, because public tax dollars, guess what? You're able to get that information. We were able to do the math. Here's how much the payroll is. Here's how much they're putting out in health benefits for retirees and actives. What is that % of payroll? Oh, look here's Senator Sheila Kuehl's bill that has just been, the financing came out on the fiscal note. It's only going to be 8% for the employer. They're paying 18% right now of payroll. We were able to go to every one of the school boards and say, look how much money you will save for kids, right? For education needs. This is crazy. You're supposed to be like guardians of the public dollar. You've got to support single payer. And we would make the case and get school boards to pass resolutions that then we would take up to the legislature and take to the specific legislators for those school district the legislative districts. So anyways, all of those kinds of things kind of work hand in hand, but that is part of a massive campaign that still has to go on around educating trade unionists on why this is a much better way to go. And they've got to stop thinking that, oh my God, especially under Janus, right? The Janus decision was huge for public employee unions. They believe that this ties them to, you organize with us and you're going to get a better health benefit than if you're an unorganized worker, or, pay your dues to us, right? Don't be a freeloader under right to work. And I get it, but my God, there's an awful lot of things that we could be bargaining at the bargaining table right now. This just doesn't have to be this albatross around our neck. And quite frankly, we're not doing all that well at being able to actually bargain it in the first place, because we're always fighting with each other over who's going to pay the cost of these increased premiums and never deal with why do they cost so much in the first place. We have a common enemy with management when it comes right down to it. So I don't know that I have a silver, or magic fairy dust or whatever on this, but that's some of the work we're doing in Minnesota. I'm regularly meeting and having breakfast with the president of Education Minnesota, just as chair of Healthcare for All Minnesota, and we're brainstorming this and bringing them in even on these incremental steps of building public infrastructure, and they seem to be really interested. So hopefully we'll be able to keep them engaged with us, and they won't, at least like you said, at least they won't fight us.
Oh, Peter.
Hey, Peter.
Oh, well, before I ask the questions, I'll just say that I remember I was at the conference of the labor campaign back in 2009, and I remember that presentation that CSEA did on the campaign in California, and it swept me off my feet. I don't understand why that strategy has been used elsewhere, more aggressively, because
Yeah.
it just seems like a winner. It goes to the heart of so many things. Um, Three questions, two of which are short, and one of which I think is a little more complicated. First of all, in Minnesota, are you operating with a coalition or is it a membership organization? I notice you pay a lot of attention to leadership development and that kind of thing.
So right now we do have the Health Justice Allies up and running. And so there are, like I said, there are all kinds of community organizations. There's immigrant rights organizations. There are some labor unions. We do have some representation from public employees. We have SEIU in the room. Of course, the nurses are there. We have the Minnesota AFL-CIO retirees. We have also some LGBTQIA organizations that are involved. Gosh, I'm just trying to think, women's reproductive health organizations. So we have kind of a core group, but we haven't moved them yet into like an actual campaign, because all of those organizations have 50 million things on their plate, right? Those of us in the organization, like a One Payer States or a Minnesota, or Healthcare for All Minnesota, or New York Health Act, this is our issue, right? This is all we're working on. But a labor union is working on a lot more than just, even though they may support this, right? Or there may be various community organizations that are working on many things. So we've got them in the room, but they have, and I've always thought coalition building, we should build this campaign together. And they're kind of like, yeah, we're sort of busy. Why don't you put together a campaign plan, give us something to chew on, we'll put feedback, and then we're going to have to make the hard ask. If you want this thing to happen, if you think this makes sense, then you need to make a commitment. And those resources, whether that is you write us a check so we can hire people to like do campaign management and organizing, whether that is loaning a staff to be able, on a part-time basis from your organization, or even whether that is something as simple as doing in-kind things. You could print all of our brochures when we go, we're getting ready to go to the state fair. Ann's gearing up for that here. We're going to see hundreds of thousands of people, here in Minnesota with a state fair booth. So we do have a coalition. We just need to get serious with them. And that's why we're putting so much emphasis on this plan that I kind of gave you a peek at.
The other questions. First of all, I noticed the reference to the public option. I remember when that was considered the enemy, I gather our thinking about that has evolved somewhat. The specific to California, and HMOs are a huge issue in California because, Kaiser, the mother of all HMOs, dominates the California market. And it's not only an insurance plan, it's also where 9 million Californians
healthcare.
go when they need to see the doctor. And it's
That's
also
right.
like 100,000 workers have collective bargaining agreements that are covered by collective bargaining agreements with Kaiser. And it's been, I'm struggling to come up with a way to approach that issue that, brings people together. So, I mean, is this an issue in Minnesota? How do you deal with it? And just generally, because it's, how do you reconcile this large, in some ways, very effective healthcare delivery system with its insurance component? How do you separate them?
Yeah, we got one of those here. Health Partners is actually both an insurer and a provider at the same time. So we don't talk about it any differently than you do in California, that nobody says you can't keep going to Kaiser. You get your health care from Kaiser. They're just not going to sell you the insurance because they don't need to do that anymore, right? They can put their money actually into healthcare. In regards to the public option, so Healthcare for All Minnesota didn't take position on the public option. We have a million questions. We are deeply concerned about it. We are very, very worried that it could be actually a step backwards because the public option isn't public. Now, that is not News to probably many of you who, anybody here from Washington, Colorado, some of the states that have tried privatized public options. It makes me crazy, right? It's it's an oxymoron because they're actually just continuing to use private insurance, but use the vehicle known as Minnesota Care, the basic health plan here, to try to do a public option. I don't know what to tell you about this other than we've got a fissure in our movement here in Minnesota because of it. We have some very, very powerful organizations that are supporting the public option. They're upset with our leaders, our single payer leaders in the House and the Senate, because those leaders kind of called this out and said, this really isn't good public policy, and we could do something different to deal with some of these issues that you're raising, and some of the issues are legitimate that I even talked about here tonight. So this is kind of trying to be the healing summer. I'm going around and trying to meet with leadership of those particular organizations that support strongly the public option to find out where we might have some common ground to do some work together going forward, particularly around the fact that at least make a public option actually public. So the deprivatization piece is pretty key there. I don't know what else to tell you other than it is about relationship building and trying to stay connected to one another, keep the lines of communication open, try to keep us from using nasty language with each other. Things like, so-and-so tanked the bill, and, things that just are not helpful for the movement overall, because we all want the same thing, which is ultimately healthcare for everybody, with none of these crazy obstacles that these corporations put in place. So I'm hoping that we can, we're working right now on actually having a meeting where we will sit down with the proponents of the public option and us, and have a conversation about what our concerns are and why they're there, and why we are really worried that this may very well not be particularly good public policy that leads us in the right direction. I keep saying the more we give this industry money, that buys them power. And the more power they have, they're fighting us every step of the way from getting healthcare reformed. Why would we do that? Why would we layer on, another privatized public plan? I will tell you that part of the problem, I think, when this was introduced, particularly in 2024, is that we didn't necessarily have a good counter narrative, meaning something to say, well, we do have some ideas on how to expand coverage and to deal with some of the cost issues. And I'm meeting with some of these legislators now that are key on this kind of legislation, and they actually are coming up with some ideas for the 2025 that can help, sort of smooth over as we're working towards the Minnesota Health Plan instead of a public option type of thing. So I'm feeling more hopeful. And I've even raised some of those issues with some of those leaders in the public option proponent campaign, and they seem a little bit interested in some of those things. So I guess I'm just crossing my fingers and hoping we can get through this, because it's hard. This is hard work. It's organizing, right? Yeah, Mike, go ahead.
Yeah, the messaging of villainizing CEOs and so forth is appealing, and we've seen it work, especially with dark money and election campaigns. It worked against Truman in 1948, villainizing somebody. And yet the Quaker influence in some of our important leaders here in Oregon just cannot stand the game of blame.
Mm.
And so we're deciding whether to use those pictures of the insurance CEOs who earn millions of dollars a year or not.
Mhm.
Or if
Right.
we use them, how do we modify it? These are not villains, they're business people. It's just that they're in the wrong business. How do you phrase that, or can you soften this and retain some of our conservative friends?
Well, I'd have to think about that, Mike, because I haven't softened it and I don't care to soften it. But that's me personally. And I mean, for instance, I wrote a letter to the editor for the Star Tribune just a couple of weeks ago, because here in Minnesota, United Health has at Medicare Advantage folks, and these that Health Partners that I told you about, the Kaiser equivalent here. I mean, not anywhere in size like the 900-pound gorilla Kaiser, but Health Partners, guess what? They're fed up with these United Health Medicare Advantage plan the United Health, because they're not being reimbursed for care that they're providing. These are this claims denial stuff that, you know, we're all hearing about, and it's some of it's related to the AI and algorithms and stuff. So Health Partners has said, we're not going to take Medicare Advantage plans. If you've got a United Health plan, we're not going to take you anymore. Well, that is a pretty devastating blow, because here in the state of Minnesota, there's a statute for state employees that says they are guaranteed health benefits as retirees, which is wonderful, of course. The state controls what those plans look like, and they put everybody into United Health Medicare Advantage plans. So we have got a huge, you know, going back to a little bit of what Richard said, right now we've got a bunch of both teachers and state employees, AFSCME, Education Minnesota, who now can't access their doctors that they have been accessing for a long time, because they can't go to Health Partners anymore, because that is out of network and they would have to pay out of pocket. So what I was trying to do with my letter to the editor, and in talking with some of these retirees, I said, be sure you know why this has happened. Don't you blame Medicare. Medicare didn't make this decision. The government didn't decide that you can't use Health Partners anymore. United Health decided that their profits were more important than paying claims for, you know, treatment that your physician, you know, the trained physician who's actually in a room with you, assessing you and diagnosing you, has determined you need. And so make sure you point out who the problem is here. We can hold Medicare up forever privatizing the portion of Medicare that they did, but those decisions are not being made by Medicare. They're being made by United Health. And make sure that retirees know that, so that we can start to have this deep conversation about this privatization of our Medicare fund. So I don't know what to tell you, Mike. I don't know. I'd have to think about how do we soften villainizing them, because I don't think it's a bad thing to make sure that people know when they complain about high costs, or they complain about care denial, or they complain about not being able to go to a network, in network, out of network. I don't know how to do anything other than to say, where do you think that stuff comes from? It isn't doctors and nurses that decided one day they thought in network, out of network, and deductibles and copays were a good idea. That's all about having an insurance-based model. You know, so anyways, I'll think about it. But I don't know what to say. Sure.
Thanks,
ahead.
Rose.
Go ahead, Ann.
Yeah, the outfit that's making 7.9 billion in profits in a
3 months.
quarterly profits is no, we're not interested in coddling that crowd. And they make that money by denying care and deny or delay, and people are dying. I just can't, you know, anyway. So I just wanted to clarify for this really savvy audience here. I heard Ali Velshi talking, you know, since Tim Waltz was is the VP now pick for that, he was talking about all the great progressive stuff that got done in Minnesota and why he's such a great choice. And he did include, because Ali Velshi on MSNBC on Saturday and Sunday morning, I do really like him. He's a Canadian, and he doesn't understand why we don't have a universal single payer healthcare system in this country. And anyway, he was saying, and one of the things that Governor Waltz got done was he's supporting a public option where all Minnesotans will be able to buy into a public health plan in Minnesota, which is of course incorrect. I just want to let everybody know that one of the reasons we did not favor that plan is that not only is it privatized, it's a managed care product, but it really would only be offered to 110 to 150,000 people in the whole state of Minnesota. We have 5.7 million people in Minnesota. So it's neither public nor is it an option for most Minnesotans. So it's a really small program. It's going to cost a lot of money to get it up and running. It's heavily subsidized. And what you're doing is it's like 110 to 150,000 additional Minnesotans, because it's attached to our Minnesota Care, which is also really a small program. Great for the people who get it. It's like you won the lottery. You get a Platinum Plus coverage, heavily subsidized, while other people in the state of Minnesota still have to pay their high deductible, high premium plans if you have to buy on the individual market. So we just didn't see that as fair. equitable, reasonable, or something that we should put effort into supporting. So I just wanted to clarify that it's a small program and would cost a lot of money and doesn't really move the
Yeah, around
needle
$500
much.
million over 2 years to ensure
Mhm.
another 110,000 people. I mean,
Mhm.
it's absolutely crazy.
Mhm.
And yeah,
So-
walls. So the public option is probably going to come back again in the next legislative session. And the most important part of what Ann just said is that when they say all Minnesotans will be able to buy the public option, that's 100% not true. That it is 100% not true. That is not even how the bill is structured. It isn't open to all Minnesotans. It is open to only Minnesotans who are buying on the exchange, that would, because they don't have employer, provided health care, or they don't have Medicare or Medicaid or whatever. So yeah, it's all these nuances. People like to take that and run with it. I mean, it's funny, Wendell Potter, our friend Wendell Potter, did a piece on walls in his Substack stuff, and I got it, and he talked about the public option thing in there. And so I forwarded, I said, hey, Wendell, got some time? We should chat. So he's, him and I think will be talking on Friday. So he has a little more background on that.
And what's odd about it is we passed a paid family and medical leave bill, and we passed it. It's a publicly administered, FICA type proposal. It's not privatized. It's public. I mean, we've done some good stuff that is
Absolutely
structured properly. This thing is an outlier, and we just, for some reason, healthcare tends to get screwed up.
And with all the good progressive stuff that has happened in our legislature over the last couple of years, and Wall certainly has been a part of that, they really, quite frankly, other than this, this sort of incremental work that I laid out for you all tonight, which I think is important stuff. It isn't like headline grabbing, though, right? I mean, people don't get into, oh, we're doing a study on administrative laws, right? But it's good work. But I mean, Walls hasn't put a ton of focus on real significant healthcare reform during his tenure so far. He is a strong labor supporter. He has done some incredible work for the immigrant community. I mean, he really has done some really strong work, and I'm thrilled he's on the VP, on the ticket, and I recommend everybody take a look at him. And he's a good guy. I mean, him and I have gone round and round a couple times on some stuff with the nurses, but he is a nice man, and he's always willing to listen and sit with you and talk it out. He always gave us complete open access, so he'll listen to us. He will, and I think we can push him along with Harris on a national level, even if they're not going to do Medicare for all. But I think we can really make her help her understand Medicare Advantage has changed dramatically since she was plugging Medicare Advantage for all when she was running for president in 2020. That's not the path we should go down. We've got lots of evidence now that shows that's not a good program, and to get her to see it the way Biden has been seeing it and recognizing that there are some problems there, and get them to keep working with us on a national level to do better for inside of Medicare. So that's my
it's just worth saying that Tim Walz was my congressman for 12 years.
Yes, Mark.
And he's never been strong on healthcare stuff. I did a fair amount of lobbying when he was in Congress, and except for the first year when he had his chief of staff was his health LA, he's never had strong staff on healthcare. And that's fine. You got to focus on something, but it's not been his strength.
Yeah, exactly. So when people have been asking me from around the country, where is he at on healthcare? I mean, he made, when the nurses interviewed him, I mean, they got like really hard on him about, if that bill, the Minnesota Health Plan, gets on your desk, we want to hear you say you will sign it. And he kind of danced for a little bit. And then one of the nurses were like, I'm going to ask it again. If it gets on your desk, this is a yes or no question. And by golly, she got him to say it. And he said, yes, I will sign that bill if it's on my desk. So it was just kind of funny. God bless nurses for pushing. So Wendell has never bought into the arguments again. Yeah, no, Peter, I know that we've got, I mean, listen, Hey, Peter, Kip Sullivan is even to some degree not sure that we shouldn't try to do this public option thing if it's deprivatized. And so I'm like, there's way more stuff going on with that than just deprivatization.
No
But
one has a monopoly on wisdom here.
yeah, well, we work closely with them, so we understand.
Well, in any case,
Don't be sorry.
regardless, the strategy question. I mean, I love talking strategy with you. You're one of the best strategy thinkers in our movement.
Oh,
And so, you know, what we've been doing at One Pair States, and I think you can grab this pretty quickly, is radically visioning, right?
Yeah.
Radically visioning. We have
yeah,
to
I love that.
we have to see the future. I think we talked about this last year. We have to see that world where we've accomplished justice for all, health and healthcare justice for all. And so what is your radical vision for us getting there? How do you see that over, let's just say, the next 10 years? Let's think in terms of Medicare for all being a moonshot project where we get this done. We get this absolutely done by 2030, 2031, 32, 33. What is your best conception? What is your best shot in the dark here? What is your best moonshot projection and scenario?
I would say, you're putting me on the spot a little bit, but I would say that the Medicare for All bill has a whole section on transition, right? Because if they passed it tomorrow, we wouldn't have Medicare for All, cards by the end of the week, right? It's a 2 to 5 year plan, depending on which bill it is you're looking at, right? To transition from the current system. So what are we waiting for? Why do we have to pass the whole bill to start transitioning to that system? So the way I don't know that it's radical, particularly, obviously there's the organizing piece of that is separate, but the movement needs wins. And so if we can get Medicare to be lowered to 60, that's one of the first things in the transition bill is they drop it from 65 to 60. They also put 0 to 18, I think, into Medicare, right? Because we want to balance out the young and the healthy, right? With the older and not necessarily so healthy. That's probably not going to happen anytime soon, but drop the age. We start to expand the benefits. We start to deal with the out-of-pocket costs inside of traditional Medicare by capping them, maybe doing away with the need for gap insurance by, doing better on the fact that it's an 80-20 plan. Any of those things are building that public infrastructure and showing that the public can do it better. And when we can start doing that with things that aren't Medicare, but in the states at the same time, because they control like Medicaid or any kind of state health programs or local health programs, and making sure the privatizers are out, the public is doing this work and doing it well, that builds confidence then, where we can show this is good, this is how we all want to have access to health care, this is how we build, like I said, that transitional infrastructure to get us to Medicare for all in 10 years or whatever. And then that's sort of the legislative, nuts and bolts piece to it, because everything we're going to do here is going to be a piece of legislation. So now we got to build the organizing campaign to get it there. But we can show some wins along the way. I think that helps bring, people into the movement. It gets them excited. It keeps them there. When I've been talking with national leaders who have been saying, there's just nothing going on with this because it's going nowhere, right? It's just not moving anywhere in the Senate or in the House. And I say, but what if we could bring back these things that were debated under Build Back Better? What if we could think about a Taft-Hartley trust that doesn't have to worry about 60-year-olds between 60 and 65 on, as early retirees on their Taft-Hartley trust. Right, retiree benefits, because Medicare picks them up, right, for the bulk of it. Those types of things can be I think, spaces where we can open up these discussions, show some wins for both providers and patients, and keep growing that public infrastructure so that we're all in it within that, like you said, 10-year time frame. That's just off the top of my head, Chuck. I don't know if that helps at all. And I don't know that it's very radical.
I think it's very helpful, frankly. I always appreciate the conversation, Rose. So you're extremely thoughtful. So thank you so much for being with us.
Thank you for having me, you guys. Always good to be here.
Yeah. Yeah, you've packed more than an hour and a half of information in less than that, and you're free to go now unless somebody has a final question.
I'm good. I think you had said this was an hour and a half, so I just figured, if you wanted to do question and answer, I'll hang out as long as you want me to. Happy to do that.
Right. And just to say too, that I think I told you I connected with Tina Smith, that there's anything you need communicated specifically directly. I've got her healthcare LA's here right now because of the Comstock Act discussion. Yeah, around Comstock Act. For people who don't know, this is part of Project 2025. This 1873 law, which the fascist Republicans want to weaponize through the DOJ to end abortion, to enact a national abortion ban. If Trump were to be elected, this would be a debacle at so many levels, but this one in particular. So this has got Tina Smith's interest very much.
Well,
And
she's
so
out of
I mean,
Planned
however
Parenthood.
let's leverage, I'm happy to leverage that, however is helpful for you all. So thank you.
Yeah, no, I appreciate that. And just so you know, Chuck, we just met with one of her legislative assistants specifically on Medicare Advantage stuff. I mean, we got Tina to sign the Warren Brown, letter that was not rah-rah, Medicare Advantage. She didn't sign the industry bill, which was huge. Klobuchar is on the other side of that. But Smith, I mean, Tina, I literally have her personal cell phone. I know Tina. She's an incredibly good human being. She really wants to figure this stuff out. She even had a stock letter that mentioned value-based payments and incentivizing quality. So I took that right in and said, we need you to stop doing this because none of this makes sense and it's not working. And so figure out some different kind of language because that stuff's crap. Don't promote that, please. And they literally were like, hey, thanks for educating us on what this means and how it's not working. And we're going to look at maybe doing some different language in that form letter that goes out, So she's very easy to work with, and I appreciate that. We're trying to get her to actually do a rural health roundtable where we can bring up how Medicare Advantage is impacting and exacerbating the rural health crisis in this country because of these claims denials and the things that are going on with Medicare Advantage. So fingers crossed that we might be able to we wanted her to do it for August recess, but I don't know. Now with Walz on the ticket and, I mean, it's all election. So I'm pretty sure we're not going to be able to probably pull that off.
Okay. Well, good to hear. You've got a friend in DC.
Yeah. Love her. Yeah,
And
go
Betty's
ahead,
up.
Betty. Yep, go ahead, Betty. Oh, you're on mute.
Betty.
So a brief question, because I think the answer is just going to be no, but then a different question. So not just thinking of regional as in like your next door neighbors, but also thinking of collaborating with other states in case some of the infrastructure that you need to build, the administration and all, you could, I mean, a lot of stuff is done remotely, Are you looking at or whether there are partners you might have in different states, if other states were moving along at the same pace?
The only thing that I have been at least privy to on a conversation, and this would go like to Peter and if anybody else is here from California, but the work that you all did in partnering as a state with, I think, generic pharmaceutical company around insulin production, maybe. I can't remember if like something like Narcan and EpiPen, because those are like life-saving, life-sustaining, right? That the fact that you all are doing that, as a state, a private-public partnership, but in a way with these generics that really make those particular types of drugs honest to God affordable, right? And we were talking, because I was talking again with Representative Liebling and Senator Marty about that, and Senator Marty says, well, maybe we just why do we have to do a state one here in Minnesota? Why don't we just collaborate with California if they've already got a generic, right, pharmaceutical company doing this stuff, and we could just purchase through them. And so that's the only thing I've ever heard about, not a collaboration as far as the actual implementation and running and administration of what we hope will be the Medicare, the Minnesota Health Plan. So no.
So that's interesting because my second question was actually, you know, the slides went really fast. I'm hoping that you
I
can
know.
share your
Yeah,
slides.
I'll send them out. Sure,
But
yeah.
But did you have anything in there about having a state formulary and getting rid of pharmacy benefit managers and stuff like that?
Well, you know what? That's another one of those things that I think could be a stepping stone. I don't think we have to wait to pass single payer to do that. We have had some conversations actually again with leaders in the House and the Senate about why doesn't the state just become the PBM first for, you know, we don't like PBMs, but you get what I mean. Why
Yeah,
have a middleman, right? Like just the state actually handles the pharmaceuticals for all of the state programs. And then eventually they could add even private sector into that. And, you know, that could start to purchase through the state program as opposed to, you know, having all these private PBMs and everything else. I don't think we have to wait. I really don't
Right.
think we have to wait for the full bill to be passed to do some of that kind of stuff. And I think those types of things would really make a difference for patients and providers, and they would feel that immediately, and it would be a good feel. And again, we can hold it up and say, see, the government
Yeah.
did that and they did a good thing.
So if you get any traction on that idea, if you could, you know, introduce me to someone, that would be super to talk with my legislators as well. And as far as those other bills, I'll try to check in with you later about where you get on that. But Vermont wants to be looking at some of those bills about protecting your infrastructure from privatization. And so I'd like to see model languages from some other states.
Yeah, I got connected to a guy out in Connecticut, Sheldon Tobman, I guess his name is. I'm not sure if any of you know Sheldon. Okay.
Yeah.
Well, we're bringing him in to do a presentation that will include some of our lead legislators on Thursday to talk about how Connecticut deprivatized their Medicaid and see if we can learn some lessons from that. You know, what obstacles did they run into? And now it's been deprivatized for a while, so they got some data. So is the data producing what we hope, which is cost savings that then can be turned around and actually put back into direct care for patients, right? So we're hoping to, so more to come on that. I'm really excited. We're also and talking about coalition building, I've invited the Public Option Coalition leaders to come and listen to that too, because they do understand public should be public. They just really feel that deprivatization is going to be really hard, and that that the first step should be at least starting to build the infrastructure of some kind of a public option, even if it's privatized for starters, and then privatize it down the path. We're looking at it the other way. We think you do the deprivatization first, and then we talk about how would we expand it out, right? But anyways, yeah. So good questions, Betty.
And I think New York is doing something with drugs too. I was actually thinking that they were the
I think
ones
so too.
yeah.
New York's always been innovative with that kind of stuff. And New York is the other state that has a basic health program like we do. And I think you all just got a waiver to increase the eligibility from 200% of federal poverty level to 250. I think that would be a better way for us to go than creating this brand new public option thing. Why don't we just take our basic health program and heck, up it to 300%? That'll cover a lot of people in the exchange and give them access to a really good health plan, because it's a 94% actuarial plan with very little out of pocket, and it's all income based on how much you pay. So it's 20, 30 bucks a month on a premium, and you got access to a platinum plus plan. I mean, it's a good plan, but it's privatized, and we don't know how they're spending our money once we give them the capitated rate to take care of that patient population. And that's the transparency stuff we need to get at to expose them.
Rose,
thank you so much, Rose. This has been fantastic.
Thank you so much. We
No,
want
thank
you to
you
come
all.
back, so we don't want to keep you longer. Okay. Thanks
No,
again,
thank
Rose.
you.
No, thank you all very much. Always good to be here with y'all. Take care. Bye-bye.
Bye.